Margaret, before Björn introduces you to the attendees, can you please explain in brief what you will talk about today?
Yes, sure. Would you allow me to share my screen?
Yes, yes, of course. Just now a message should appear at your screen.
Okay, so can you hear me still?
We can hear you and we can see your slide.
Okay, great. So in the next 35 minutes or so, I want to review with you the underlying causes of the exceedingly high rates of cardiometabolic comorbidity in schizophrenia spectrum disorders, and share with you some of the work we've been doing in terms of the role of the central nervous system in mediating some of these disturbances. Then I'm going to switch gears, put on a clinical hat, and tell you about our updated Canadian Obesity Guidelines that for the first time have a section in relation to managing metabolic comorbidity in severe mental illness. And then finally, I'll speak to how these recommendations may be implemented into clinical practice and research, also in relation to what we're going to do as part of the DDA visiting professorship when I get to come to Copenhagen.
Thank you. Björn Ebdrup, will you please introduce Margaret Hahn?
Yes, thank you. And thank you all for joining. I've really been looking forward to this webinar with Margaret Hahn. And the reason for having this webinar is that Margaret was granted a visiting professorship here at Mental Health Center Glostrup, and at also with Professor Philip Krag-Knop from Center for Clinical Metabolic Research at Gentofte Hospital in Denmark. Margaret Hahn is a clinical scientist at CAMH, and which is Center for Addiction and Mental Health in Toronto, Canada. And she leads the metabolic clinic at CAMH, which is one of the first clinics to set up a sort of a setup where they have simultaneously attendance to the metabolic problems of patients as well as to the psychiatric problems of patients with severe mental illness. And she will be talking about these, how they implement these problems in or these issues in their setting. And we are very much looking forward to Margaret visiting us in end of summer, if restrictions allow, to see if we can implement some of these issues in Danish psychiatric setting. Margaret, please continue with your talk. I'm looking forward to that. And please, attendees, if you have questions, put them in the chat while Maggie is giving her talk, and I will try to manage them at the end. So please.
Okay, great. Thanks for that introduction, Björn. So I've gone through my objectives. Now, can I flip my slides? That is the question. Okay, and I just have one disclosure. So I think it's very well established these days that patients with severe mental illness, and I'll refer to severe mental illness during this talk as SMI, lose about 20 to 25 years of life, and that is directly attributable, in fact, to cardiovascular disease. This is then in keeping with prevalence rates of metabolic syndrome, which are twofold higher in our patients, and prevalence rates of type 2 diabetes that are 3 to 5-fold higher in our patients as compared to the general population. When we think about why this association occurs, perhaps not surprisingly, it's not a simple explanation. So we have lifestyle factors that contribute. We have system factors, including this historical separation between physical and mental health care. There are fascinating aspects of illness biology, in particular an intrinsic risk of diabetes that exists in schizophrenia that we'll touch upon. And then finally, we have our treatments, which across different psychotropic agents, but in particular, when we think about antipsychotic medications, cause very significant metabolic side effects. So why do we care about antipsychotics? Well, as you may know, they're the cornerstone of treatment for schizophrenia. They now have approval across a number of different severe mental illnesses, and they're also being used in many cases in an off-indication or off-label setting. Historically speaking, it was really the introduction of so-called second generation or atypical antipsychotics into practice that really shed light on the significant metabolic comorbidity in schizophrenia and other severe mental illnesses, as well as the significant metabolic side effect profile of these antipsychotic medications. So what we've learned is indeed these drugs aren't created equally in terms of metabolic risk or propensity. And unfortunately, our two best antipsychotics, clozapine followed by olanzapine, in terms of efficacy, also carry the highest metabolic burden. What we've also learned is where you intervene, like at what stage of illness, and actually makes a difference into the magnitude of weight gain and perhaps other metabolic abnormalities that are experienced. So for example, if you take antipsychotic naive, first episode young individuals with psychosis, you can see that a medication like olanzapine causes an average weight gain over time of 17 kilograms or 40 pounds. So that's about 3 to 4-fold higher than what's seen when we introduce these treatments into chronically ill patients. And you see a similar phenomenon with lower liability agents like older generation antipsychotics like haloperidol, as well as some of the newer agents, now third generation antipsychotics that were marketed as being metabolically neutral, but that may not be the case again in previously unexposed young patients. Similarly, supporting the concept that there are no metabolically benign antipsychotics, this was a large Danish, actually, population-based cohort study that was published, and that demonstrated really nicely that beyond the risk for diabetes that's conferred just by having the illness of schizophrenia, that risk is further increased across first generation as well as second generation antipsychotics, really across all agents by another 3 to 4-fold. And when we think about implications of metabolic comorbidity and these side effects, they extend beyond cardiovascular considerations. They impact medication compliance, self-esteem, quality of life, and certainly incur social care costs. As well, we're beginning to view diabetes and obesity not just as chronic, severe medical illnesses. They are illnesses that also appear to impact the brain. Having these metabolic comorbidities, in particular dysglycemia, is associated with worse cognitive functioning, as well as neurological alterations, including volume loss in key regions important for cognition, like the hippocampus. And we're seeing similar associations in schizophrenia. So this was a large meta-analysis that was published several years ago now and demonstrated that in patients who have metabolic syndrome or diabetes, they perform worse on cognitive tasks than patients with schizophrenia without these metabolic comorbidities. Now, coming to Denmark with Bjorn, who so kindly introduced me, we will also do a small subbing where we're going to take existing data and brain scans from 2 respective RCTs in Canada and from Denmark. And we're going to look at the effects of the presence or absence of dysglycemia on brain structural alterations, and perhaps also in relation to the cognitive findings in our patient population, with the hypothesis that dysglycemia will be associated with smaller hippocampal volumes and worse cognitive functioning. Now, the other aspect that my lab's been interested in for over a decade now is how antipsychotic drugs contribute to dysglycemia and the role of the brain in mediating some of these abnormalities. So when we look at antipsychotics and type 2 diabetes, there are two mechanisms by which that risk may be incurred. So I mentioned the weight gain story, which is a leading risk factor for insulin resistance and diabetes. However, independently of the weight gain story, these drugs can also directly impact pathways of glucose metabolism. And we know this because it's very consistently shown that if you take a healthy rat, all you need is as little as a single dose of these various antipsychotic drugs to see impairments in glucose metabolism. And moreover, that model has very good translational value to humans, where similarly with short-term dosing with these agents, we see early disturbances in glucose metabolism. Now, what about the brain? Well, we've known over the past several decades that the brain is a key orchestrator of metabolism. So what happens is in the periphery, key hormones like insulin, leptin, nutrients like glucose cross into the brain, communicate to the brain what's happening in the periphery, and the brain exerts effects to regulate energy as well as glucose homeostasis. Insulin emerges as one of those key hormones that acts at the brain. And what we see is cross-species insulin, whether injected into the brain or given intranasally in humans, suppresses food intake, changes food preferences, improves metabolic flexibility, and suppresses hepatic glucose production, so lowers glucose production at the liver. Moreover, insulin receptors are expressed in other brain areas where they also have a role in neuronal growth, cognition, and synaptic plasticity. And key molecules downstream of the insulin receptor like AKT, GSK3 actually emerge as candidate susceptibility genes in schizophrenia. So these pathways and disruption in these pathways may in fact explain these pre-morbid metabolic deficits that exist in patients with schizophrenia. So for example, patients even before introduction with antipsychotics have been found to have insulin resistance and dysglycemia. Then the next question that we were wondering is what the heck antipsychotics are doing to the system. Also kind of within the concept that we know that antipsychotics don't touch cognitive deficits of the illness of schizophrenia and for which we have no effective treatments. And part of that may be because they're not repairing these broken pathways in the brains of patients and in fact maybe making some of these aspects worse. So as a proof of principle question now several years ago, what we asked is, well, we know that an insulin infusion into the third ventricle of rats suppresses glucose production. So if we administered a single dose of an antipsychotic, would it disrupt this pathway, which would then support the concept that these drugs were causing insulin resistance at the central nervous system. So we did this by measuring glucose homeostasis using pancreatic euglycemic clamps, which are a gold standard technique, which allow us to separately look at hepatic glucose production. And what happens in that technique is we inhibit the animal's own ability to produce insulin. We replace insulin by a peripheral infusion at levels that don't engage the central nervous system, which then allows us to separately manipulate central insulin levels through central insulin infusions. And with that model, what we found is indeed a central insulin infusion suppressed hepatic glucose production. And lo and behold, when we co-treated these animals acutely with olanzapine, that effect was completely abolished, which supported the notion that these drugs may be causing central insulin resistance. Similarly, we found these effects with feeding in the dark cycle. So we saw that central insulin infusion suppressed 12-hour food intake. And when these animals were co-treated with olanzapine, that effect of central insulin to suppress feeding was abolished. And why do we care? Well, it turns out that intranasal insulin was studied in schizophrenia with the hopes that it would mitigate cognitive deficits and improve some of the metabolic outcomes in patients. And the 3 studies published to date have been very negative. And while that may be for a variety of reasons, one consideration is all these patients were taking antipsychotic medications. So if indeed antipsychotic medications cause central insulin resistance, we wouldn't expect intranasal insulin to have an effect. And perhaps we should be co-treating these patients with insulin sensitizers. So as a follow-up to this work, we're actually actively doing the same trial in humans, administering intranasal insulin with the hypothesis that short acute dosing with olanzapine will inhibit these beneficial effects of intranasal insulin on cognition, appetite, and glucose homeostasis. And what's really neat is we can do clamp studies in humans, just like we do in rodents. Right now, we are dependent on another hospital to conduct these clamp studies in humans, which creates some practicality issues, in particular that we can't simultaneously do MRI scans. So as part of the visiting professorship, with the help of Dr. Philip Knopp, I'm going to learn these clamping techniques and hopefully bring them back to the Center for Addiction and Mental Health in Toronto. And the hopes is that we can do some really cool collaborative studies. So just to summarize this first part of the talk, SMI is associated with high rates of metabolic comorbidity, including diabetes. The implications of these comorbidities extend beyond cardiovascular morbidity and may impact things like cognition and perhaps brain structural alterations in our patients. The pathophysiology of these metabolic comorbidities is complicated. Antipsychotics contribute through largely unknown mechanisms, and these may involve perturbations at the level of the brain. So switching gears now, let's see what's happening in terms of our patient care. So perhaps not surprisingly, even though our patients have a greater burden of cardiometabolic disease, rates of metabolic monitoring are lower than in the general population. And this is really important because if you don't screen, you can't intervene. And as you may be aware, comorbidities like diabetes, dyslipidemia, hypertension, and smoking are considered modifiable cardiovascular risk factors, which if caught and treated can have a significant impact on health and life expectancy. But perhaps not surprisingly, again, our patients experience huge disparities in terms of interventions. So as a case in point, this was a large community-based trial across 34 community centers in the States that was published in JAMA in 2014. It looked at prevalence rates of cardiovascular risk factors in first episode psychosis patients. The average age of this cohort was 20 years old, so just keep that in mind, 20 years old. Look at the rates of dyslipidemia, close to 60%. Half of patients were smoking, close to 20% already had a diagnosis of prediabetes. Then you look at the percentage of people receiving some sort of medication intervention, and that is just pretty much non-existent. So I guess as a bit of a silver lining, it was quite exciting as over the past couple of years, I had the opportunity to contribute to an updated version of the Canadian Obesity Clinical Practice Guidelines. And I wanted to share with you what came out of those guidelines, especially in terms of pharmacological and behavioral interventions in patients who have comorbid obesity and mental illness. So when we're thinking about, firstly, pharmacological interventions in SMI, again, I think we have to remember that the underlying causes of these comorbidities like obesity may be different and more complicated in our patients as compared to the general population. And this may also mean that interventions for obesity may not work in the same way. And we also have safety concerns like, impacting the central nervous system, causing relapse and so forth to consider. This is probably also the reason that you'll see that there have been many off indication or off label, so non-approved kind of weight loss agents that have been studied in particular in the context of antipsychotic induced weight gain and trying to mitigate that. So what's available in terms of pharmacological interventions for chronic management of obesity or overweight and comorbidities? So in Canada, we have 3 agents that are indicated and approved for this indication. orlistat, which inhibits essentially fat absorption in the gut, liraglutide, GLP-1 receptor agonist, and Contrave, which is a combination of the antidepressant bupropion and the opioid antagonist naltrexone. In the US, they did have 2 additional agents approved. Locasiran was pulled off the market because of cancer concerns. And they do have 1 agent that's not available in the US, in Canada, which is Cosima, which is a combination of the sympathomimetic drug phentermine and topiramate, which is a drug that's indicated for treatment of epilepsy and migraines. So when we were doing these guidelines, and we were actually simultaneously through my group working on a Cochrane review examining pharmacological interventions for antipsychotic treated patients who experience weight gain. I just summarized in this table the agents that were examined, and you can see there's a whole slew of agents, including off-label agents. And I bolded the agents that were superior as compared to placebo across these RCTs and indicated the number of studies supporting their use that went into this meta-analysis. So right off the bat, you can see that 2 studies examining orlistat were not significant versus placebo. And similarly, 2 studies examining Contrave also were not significant versus placebo. Looking at the agents that were, sibutramine was pulled off the market because of cardiovascular safety concerns, so that is out. Nizatidine is a histamine agonist. However, the studies supporting its use were low quality, so probably not recommended. Interestingly enough, aripiprazole is an antipsychotic itself. It causes significant weight gain in first episode psychosis, antipsychotic naive patients, but it was studied to mitigate clozapine-induced weight gain and actually had a modest weight loss effect. However, again, the studies were considered to be low quality, and moreover, one of the studies demonstrated that the weight was coming off lean muscle, lean tissue, and not fat. In terms of the other agents we were left with, so there are 11 RCTs supporting metformin off-label. Metformin, as you may know, is the first-line anti-diabetic and in intervention also for pre-diabetes in conjunction with lifestyle factors in the general population. Topiramate, again, is the anti-epileptic with 2 RCTs supporting its use. And then what was exciting as compared to previous meta-analysis, we now actually have 4 RCTs supporting the use of GLP-1 receptor agonists in this population to counter antipsychotic-induced weight gain. So what came from these recommendations? First of all, looking at off indications, so non-approved weight loss agents. I think we're the first national guideline that has actually recommended that metformin can be considered in conjunction with behavioral obesity management strategies in people who are receiving antipsychotic medications and are gaining or have gained weight. Adjunctive off-label use of topiramate, while modestly effective to mitigate antipsychotic-induced weight gain, still requires larger studies and extended treatment duration, as well as more detailed examination of adverse effects. In particular, topiramate, at least when used at high doses in epilepsy, is associated with cognitive deficits, so these need to be studied better before advocating for routine use in our patient populations. Nonetheless, it's an option we kind of have in our pocket if we run out of other options. Recommendations for license, so on-label anti-obesity drugs. It does appear that GLP-1 receptor agonists can be effective and appear to be well tolerated to mitigate antipsychotic-induced weight gain. The caveat with these medications is they require self-injections, which patients don't always like. But I think the main hindrance is their expense. At least in Canada, they're not covered by most disability plans. So that is a barrier, at least in Canada. I'm not sure what the situation is like in Denmark in terms of drug coverage. And as I outlined, there doesn't seem to be sufficient evidence, at least at present, to recommend routine use of orlistat or a contrave in patients who gain weight because of antipsychotic medications. The caveat here is I think naltrexone bupropion may be an interesting alternative that can be studied in patients who have substance use or smoking comorbidity, as bupropion is used for smoking cessation. It's also indicated for, not indicated, but has been studied for binge eating disorder. And naltrexone is used for different substance use disorders, namely alcohol use disorder. In terms of behavioral interventions, these are generally divided into two groups, CBT and or nutritional exercise interventions. Very briefly, this is one of the recent meta-analyses that examine behavioral interventions in SMI. They have a modest effect. That effect seems to be sustained in trials that are longer than 12 months duration. Sometimes uptake, though, of some of these interventions and scalability is problematic. While we were writing the guidelines, this study was, however, published, the largest RCT to date, that examined a very practical group structural lifestyle education program in patients with schizophrenia spectrum disorders, and it had no difference in outcomes that were studied, including weight, any blood parameters, lifestyle changes, or cost effectiveness. So what came from these data is that, yes, behavioral obesity management can be effective and should be used in individuals with co-occurring mental illness. However, the intensity of these behavioral interventions may need to increase for individuals who have more severe psychopathology. Other key messages: monitor, so regular metabolic monitoring. When starting antipsychotic medications, avoid medications that are higher metabolic risk as first-line treatments. And if someone has gained weight on one of these higher metabolic risk agents, you can consider switching strategies. So I think it's great that we have these guidelines, but then the question arises how we can incorporate these into everyday care of patients and also into research to expand our knowledge in terms of especially interventions for these serious metabolic comorbidities. So at the Center for Addiction and Mental Health, as Dr. Bjorn Ebdrup mentioned, we're very fortunate. We have a mental health and metabolism clinic. So this clinic was established by this gentleman, Dr. Tony Cohen, well over a decade ago. Later I had, after I joined in 2013, we had Dr. Mahavir Agrawal come down. He trained as a postdoc fellow with me and has since taken a major role in leading this clinic and also the new developments that we've had that I'll share with you. And then we have Dr. Sandeep Dhillon, who's a hospitalist with an interest in metabolic care and severe mental illness, who comes and acts as a consultant for us in difficult cases. So the goal of the clinic when it was established was to offer consultations to help psychiatrists and family physicians manage metabolic comorbidities in patients with severe mental illness. Over the last 2 years, or now almost 3 years, we've also recently implemented something called measurement-based care, as well as integrated care pathways, which I'll tell you a little bit about. So measurement-based care, what that refers to is systematic administration of metabolic measures, which happens according to our best practice monitoring guidelines, alongside collecting measures of psychopathology that we believe are relevant to patients and metabolic disease in our patients, as well as cognitive function and quality of life rating scales. And the whole purpose of collecting these metabolic and quality of life and psychopathology measures is these data then drive clinical decision-making at the level of the individual patients, according also to what we call integrated care pathways, which are really just algorithms of treatment based on our knowledge and current practice guidelines. So this is just the example of what our measurement-based care looks like. So we, again, systematically collect things like anthropometric measures and fasting blood work, fasting when possible. Sometimes that's not possible. We take non-fasting as well as simple appetite and activity scales that can be, and tobacco use scales. And then very brief scales assessing quality of life, cognition, and psychopathology. Now, this may seem like a huge burden of questions, but in fact, once someone is trained, it takes about 30 minutes to do these assessments at baseline and 1 year, and less time in kind of in the middle at the 3-month and 6-month periods. And this can be done by any clinician who receives training. The data are then recorded in our EMR system and then transferred to a research electronic data capture system. And once we have RAB approval, then we can use these data for research purposes to study interventions, to look at associations between, metabolic measures and these different psychopathology measures and quality of life and so forth. And then once again, the purpose of these data are also to, in real time, drive clinical decision-making at the level of the patient, and that is guided by these ICPs or algorithms. And I'll share with you our algorithm-based treatment for people who are rapidly gaining weight on antipsychotics or who already have gained weight and are overweight and obese. So all patients receive basic lifestyle counseling advice with referral as needed to a community-based dietitian, which is covered in Ontario under our health plans. And then as needed, a referral to our CAMH nicotine dependence clinic, which we are in the process of integrating with the metabolic clinic. Then if someone meets these criteria for an adjunctive pharmacological intervention, we usually start with metformin just because it's safe, it's been around for a long time, and it seems to work well in terms of weight loss in about 1 in 5 patients where people lose the greater than 5% of their body weight. And then based on comorbidities, if metformin doesn't work or isn't tolerated, we kind of move down the list. Very briefly, some pilot data. So over 1 year, before the pandemic shutdown, which kind of shut everything down, we actually kind of had this stop in collecting data, which is very unfortunate. But we completed baseline assessments for 102 individuals. We had very good retention rates. Mean age of clients was 36 years old. Mean BMI was in the obese category, and 25% had dysglycemia, so diabetes or pre-diabetes, and 43% met criteria for metabolic syndrome. And what was really nice, we used some of this pilot data to actually secure a federal grant that is looking at people who don't respond to metformin, and we're randomizing these people to a GLP-1 receptor agonist that you may be familiar with, semaglutide. So during the visiting professorship, the main aim will actually be to establish a metabolic clinic in Copenhagen. This will be done in collaboration with Dr. Bjorn Ebdrup, who again kindly introduced me at the beginning of this talk. And we're going to set this up as a starting point at Mental Health Center Gloucester. And this will be done in consultation with our 2 endocrine experts and collaborators on this DDA visiting professorship, Philip Knopp and Tina Vilswall. I think the goal will be to align measures to those of CAMH. And the impact of this from a research perspective will be creation of an infrastructure for a real-world international clinical database, which then can be leveraged for research, whether this be cross-sectional kind of studies or double-blind randomized intervention trials. And as well, we hope to, in the future, set up a kind of responsible biobank that, again, will be international. From a clinical perspective, I think this kind of approach offers the opportunity to translate best evidence-based knowledge into clinical treatment of these patients that experience huge disparities in terms of treatment of cardiovascular risk factors. Hopefully this improves rates of metabolic monitoring, even just across the center where this is established, and increases medical knowledge and enablement of medical care and management by psychiatrists, and also helps enable collaborations with primary care providers. So I'll finish here, and hopefully I didn't go over time too much, and we'll open it up for any questions. And I should say thank you to all the people that helped contribute to this, and also to my collaborators for the DDA visiting professorship, Dr. Edrup, Knopp, and Bissell. So let me just stop sharing here.
Thank you so much, Maggie. This was a fabulous talk. We're so much looking forward to seeing you here and to get started with all this work that is awaiting us. I have quite a few questions coming in here. So I think I have a few questions, but I'll wait with those. So I'll just start reading these aloud. From David Wright, who says, we see a potentiated effect of SDAs on the development of hyperglycemia in obese versus lean mice. Do you think this could be linked to the presence of central insulin resistance in the obese mice?
Yes, it could be, is the short answer. That would be actually very interesting to work on and see, because certainly adiposity causes insulin resistance. Even 3-day high-fat diet feeding causes central insulin resistance in healthy rats and mice. So absolutely.
Yep. And he also writes a second question here, David Wright. Some of the effects of metformin on weight loss in type 2 diabetes seems to be explained by GDF-15. Have similar relationships been examined in individuals with severe mental illness being treated with metformin?
No one's looked at that question. I think it would be fantastic to look at that. And we actually have blood samples sitting from our RCT, and we could see, you know, if the people who lost weight, maybe that could be explained by this molecular marker. So it hasn't been done. We're actually just submitting a clinical trial looking at metformin in people with intellectual disabilities. That would be that's one of the markers we'll be looking at. So, but it hasn't been done to my knowledge in people with schizophrenia spectrum disorders. And
Jenny Brown says, great talk, and I can only echo that. What are the primary brain areas of that antipsychotics target, and do we know what cell types that contribute to the deleterious effects of metabolic effects? And is anything known about antipsychotics and inflammation in the brain / gliosis? So 2 questions. The primary brain areas of antipsychotics, and do we know what cell types contribute?
Well, antipsychotics hit every area of the brain, so they probably impact rewards settings that may contribute to overeating and binge eating that some patients develop when you introduce these agents. They probably target the hypothalamus, the DVC, cell types. There's been some work done on NPY, AGRP, and the data are kind of variable, which maybe depends on some of the techniques that have been used. Antipsychotics and inflammation, I think I'm not super familiar with that literature. I don't know, Bjorn, if you are, but my guess is that it's probably variable. I think there's some studies that think that antipsychotics are anti-inflammatory, some studies that show that they're pro-inflammatory. Certainly if they increase adiposity, that's pro-inflammatory in itself. So I think the jury is out, and there are just so many confounding factors in our patients that I don't think we have an answer to that question. I don't know if you're anything else.
No, I think that's a good question, and I think it needs to be, and it also depends on how you actually ask the question, whether you think that psychosis in itself is an inflammatory disease, and part of the effect of antipsychotics is by de-inflammation, but it still needs to be resolved, I think. Okay, and then Ashok Ganeshalemiga, I'm not sure, Ashok is writing, "Hi Maggie, thank you for your great talk. Do you have any data concerning preventive treatment of metabolic syndrome prior to weight gain when initiating antipsychotic treatment? Recent Danish studies show that the biggest weight gain appears within the first year of antipsychotic treatment. What are your thoughts on preventive treatment? That is, for example, metformin, GLP receptor agonists, when initiating treatment with antipsychotic treatment in order to mitigate metabolic disturbances and reduce cardiovascular risk."
Yeah, so there's a huge gap in looking at anything beyond weight gain in these populations. So to my knowledge, I don't think anyone's done a preventative study looking at metabolic syndrome per se. It does appear that when you intervene with metformin early on, it has a bigger impact than in chronic populations. I don't know if I'm still sharing my slides, but when we did our, maybe I can just quickly share my slides here. Let me just see. Share. Okay. So I don't know if you can see that, but when we were working on our meta-analysis and we looked at metformin, and we saw a huge heterogeneity among the studies. And what happened is when we split the studies up into first episode psychosis patients versus chronic patients, that heterogeneity disappeared. And you can see that in first episode psychosis patients, when you intervene early, the weight loss with metformin is about 2-fold higher. So it's about 5 kilograms. Whereas if you intervene at the chronic stages, it's about 2 kilograms. So this is also an important question. I think what we need is a multi-center prevention trial of metformin to try to answer some of these questions. And again, looking beyond just the weight gain story and looking at prevention, you know, of these other changes associated with aspects of metabolic syndrome that occur. So let me just.
And we have one more question here. Thank you for the talk. That's from Maria Hornstrup. Are men and women with SMI equally susceptible to weight gain and development of diabetes? And likewise regarding young versus older people with SMI? So gender
Yes.
and age.
So, I mean, when you look at rat models, and David, right, can also comment on this, we struggle to replicate weight gain in male rats versus female rats. Female rats are better models. So there's been this question of translation value of rodents and this question of whether this is limited more to females. It does appear that females in clinic are more susceptible to some of these metabolic side effects. However, it's also indisputable that these side effects happen to men as well. So I think as well, that's a question that needs to be kind of better teased out and what the different driving factors may be. And David can comment on this. David, right? He's published on the gender effects and looked into actually GLP-1 signaling. So maybe he can also chime in. And regarding young versus older people, I think age has come in as a risk factor, but what's more consistent than young age is actually previous antipsychotic exposure. So when you're introducing these treatments for the first time, that's when you see the largest weight gain. That's where most of the weight gain occurs. That those side effects tend to be less prominent in chronically ill populations, and that has to do with previous exposure. So a lot of these patients have had, exposure to many older antipsychotics, also had longer exposure to lifestyle effects related to the illness. So poor diet, inactivity that comes with some of the symptoms of schizophrenia, and some of the sedating side effects. So there's kind of a ceiling effect reached. So when you introduce these drugs to chronically ill populations and older populations, you don't see as much of a change because they already have some of this burden, metabolic burden that's accumulated.
Yeah. It's a confounding by disease. I have one. I think there were no more questions in the chat, but I think actually, you presented these alarming data from the JAMA Corel study 2014 about the presence of metabolic disturbances early on in disease, and you have your chart of how to intervene in your metabolic clinic. But I think the alarming results showing that, more than 50% of these 20-year-old young people are actually having metabolic disturbances to some extent. When should you start intervening? Are we already too late?
Yeah, I think the train's left the station, so to speak. That doesn't mean that you still can't intervene, and we should be intervening. But I think that these programs need to be very intensive in the first episode psychosis populations. And I don't know that I would start, everyone on a preventative medication, because there are some lucky people that, go on olanzapine, don't gain a pound. But that's the minority sort of people. And the best predictor of, metabolic abnormalities in the future is just even the first 2 weeks of treatment. You will see the individuals who are going to gain weight, they start gaining weight. So I think very close monitoring from the very the onset of the first psychosis episode, and intervention as soon as we see these metabolic abnormalities arise. That would be my sense.
And related to that, I suppose that, I realize that this is the Danish Diabetes Academy session here, but I guess there are other, we talk about blood sugar here, hyperglycemia, but I think dyslipidemia as well. They have lipid disturbances and high blood pressure and all these other parameters. You could also, I guess, start intervening. How much do you do with that?
Yeah, and actually, I'm hoping that as part of the DDA, we can develop algorithms for those risk factors. Like right now at our clinic, we focused on the weight gain story, and we manage the dysglycemia story to some extent. And when things we're psychiatrists kind of managing this stuff. So we, then we refer back out to the family physician and say, like, listen, this person has high lipids and hypertension. Please intervene like you would to anyone kind of in the general population. And then we have an endocrinologist that we also kind of reach out to in like severe cases where someone, has a very significant metabolic comorbidities. But I'm really, really hoping that as part of the DDA visiting professorship, we can develop these nice algorithms for these other comorbidities beyond just the weight gain story, because we know that some people don't even gain weight, but they independently, again, of weight gain, they develop dysglycemia and dyslipidemia and hypertension. So
great.